Thank you, Sean. Good morning, everyone, and welcome to this important webinar sponsored by the Michigan Department of Health and Human Services and the Michigan Health and Hospital Association on monoclonal antibody therapy. So my name is Dr. Jonae Caldoun. I'm the Chief Medical Executive and Chief Deputy Director for Health at MDHHS, and I'm really looking forward to the presentations today. But before we get into our presentations, we have a special message from our Governor, Gretchen Whitmer.
Hi, everyone. I just wanted to say good morning and thank you for all of the incredible work that you are doing, continue to do, and have been doing for so long. I know it has been a horribly tough time, and as heavy as my burden feels some days, I know it pales in comparison to so many who've been on the front lines of this pandemic for so long. So I just want to thank you. I hope you've got a good day. Appreciate the work that you're doing with Dr. J and our team at DHHS. And I am getting my second shot next week, and hopefully that means our paths will cross soon so I can thank you in person. But until then, I just want you to know how grateful I am and how grateful our state is as well. Bye.
Join the governor in thanking all of our hospital partners joining us today for their tireless efforts for over a year now fighting this pandemic. Whether it's taking care of patients, testing, vaccination efforts, the efforts of you and your staff have just truly been heroic, and I am truly grateful. So today we are talking about another important tool in our toolbox, monoclonal antibodies. Two products currently have FDA emergency use authorization for use in patients who test positive for COVID-19 and have mild to moderate symptoms. The evidence base has been growing for the efficacy and safety of these therapies, and many of you are already providing this therapy for your patients. Because of our collaborative efforts, Michigan has actually been recognized by the Biden administration for its innovative and forward-thinking efforts in this space. Particularly in light of our current surge, we want to significantly expand our usage in the state of Michigan. Our overall goal is for 50% of people who are eligible to receive this therapy in this state. And to do that, we want every person in Michigan who tests positive for COVID-19 to be screened for and then offered these therapies if they are eligible, and for them to have no barriers to access wherever they may live in Michigan. So we're going to hear a lot more about that from our partners on today's webinar, as well as promising strategies at the federal, state, and local level. And with that, I will turn it over to Gary Roth, our Chief Medical Officer at the Michigan Health and Hospital Association, to share a few introductory remarks.
Well, good morning. And on behalf of the Michigan Health and Hospital Association, MHA, welcome to this webinar on expanding use on monoclonal antibody therapy for mild to moderate COVID-19. I'm Gary Roth. I practice surgery and critical care in Lansing, and I now serve as the Chief Medical Officer for MHA. You know, there's never been a time when collaboration within the healthcare space has been more important than now. And if there's a bit of a silver lining throughout this crisis, has been these partnerships that have evolved. This webinar is an example of that very thing. Now, since there are more important things to discuss and experts to hear, I'll keep my comments very brief. As you're aware, MHA is devoted to the care of our patients and the health of our communities. We are in your corner. We have remained in your corner throughout this crisis. We all know our opportunities to prevent, to control, and to treat COVID-19. Community efforts, you know, we know verbatim of masking and distancing and washing our hands. We dream those things in our sleep now. And of course, the opportunity to prevent COVID with vaccines, which is nothing less than a scientific marvel, are available to every Michigander over 16 years of age. But it still remains an uphill battle getting shots in arms, and we're going to continue to fight this tooth and nail. Our hospitals, those of you on this webinar, are caring for patients that are dealing with issues unlike what we have ever seen in healthcare. Frontline providers, support staff, first responders, and everyone that touches a patient or supports those that do are working day and night. And MHA is there and continues to be there 24/7, providing the assistance where we can. And then today's topic, there are therapeutic modalities, including those that focus on keeping COVID positive individuals well and out of the hospital. And that's what we're going to discuss over the next 50 minutes or so. So with that said, I appreciate the opportunity to be part of this conversation. MHA truly is a devoted partner. And I will, with that said, I will turn over and relinquish the podium to our next speaker. So once again, thank you.
Thank you, Dr. Roth. We are certainly pleased about the partnership with MHA throughout this entire pandemic. So with that, we are pleased to welcome our first presenter, Dr. Michael Anderson. Dr. Anderson. Oh, if people can mute themselves if they are not speaking.
Hey, Dr. Khaldun, sorry, everyone got unmuted, so I muted everyone. If you want to mute.
Oh, I'm muted again. Okay.
Yeah, sorry for that.
Okay, I'll start again. So Dr. Michael Anderson is our next presenter. He currently serves as a senior advisor in the Office of the Assistant Secretary for Preparedness and Response in the U.S. Department of Health and Human Services. Dr. Anderson is also an adjunct professor of research and leadership at my alma mater, the George Washington University, in the School of Medicine and Health Science. He's a trained pediatric critical care physician and is the former president of the UCSF Benioff Children's Hospital in Oakland. So Dr. Anderson, thank you for joining us and really for all of your efforts with the federal COVID response team.
Dr. J, thanks so much. Can you see my slides and hear me okay?
Yes. Yeah.
Great, thank you. Good morning, everybody. It is an honor and a pleasure to be with you today, and I will take about 15 minutes. Dr. J and Dr. Fales asked me to sort of give a 25,000-foot view of how the federal COVID response, FCR, used to be known as Operation Warp Speed, we're now the federal COVID response, how we see monoclonals. But it's an honor to be with Michigan leaders because as you look across the country, and Dr. J said this, we see states that have really risen to this therapeutic challenge. Obviously, Michigan has a lot of challenges that you're tackling each and every day, but look at how public health and hospital leadership and medical professionals and emergency managers have all come together, and we just want to continue that. The second reason I'm proud to be here is when we look across the country, probably, and Dr. J once again alluded to this, 20, maybe 25% of eligible patients are getting these antibodies, and I give Michigan leadership credit. They've said, no, let's set the bar high. Let's get to 50% of patients that need and receive these antibodies. So I'm very, very proud to be with you. I grew up at the corner of 12 and Woodward for the first 18 years of my life. And my very first job was in Brevort, Michigan in the UP. So Michigan is literally a part of my heart. So we'll talk a little bit at a high level about what monoclonals are. I know there's learned colleagues from infectious disease and other entities on, but I'll sort of just give you a primer, talk a little bit about the emerging data. This is a very interesting time because unlike, and I've been a doc for a long time, unlike most medications that come out with large trials and pharmaceuticals and take maybe 8-10 years to get into common practice, these are life-saving, ICU capacity-saving drugs that have rapidly gone from the EUA process into patients, and I know have saved lives across this country. It's just a very interesting thing for most clinicians because we're used to a longer runway, if you will. So we'll talk about the EUA, and as Dr. Fales and Dr. J said, there is emerging data that shows really the incredible efficacy. And I know I've got wonderful colleagues from Henry Ford. I'll sort of tee up the great work they're doing and President Biden's announcement from March 17th. So this is the clinical course moving from left to right. And obviously so much focus right now is on the bottom left corner. How can we make sure that patients don't get this disease? And I know that you all are dedicated to vaccination efforts each and every day. I think it's terrific that we've gone from identifying this virus to having 3 EUA approved vaccines in a very short amount of time. And that has to be the key. But we know that thousands of patients every day, the most vulnerable amongst us, still turn positive for COVID. Maybe they haven't been vaccinated or had the chance. Maybe they refuse vaccine. Whatever the reason, we know that high-risk patients who receive these antibodies have about a 70% decrease in the need for hospitalization. That number is consistent, a 70% decrease in hospitalization. And I'll show you the data that we're basing that on. What we're talking about today is this middle chevron, the light to dark blue. I'm a patient that has tested positive for COVID. I'm in the first 10 days of my symptomatology. And before these 2 EUA approved monoclonal antibodies were out, all clinicians had were hope and prayer. We would send you home because you weren't sick enough for admission, but we had nothing to give you. Now we have 2 therapies, one by the Lilly Corporation, one by Regeneron, the 2 EUA approved, that show when given early in the course, and the EUA is within the first 10 days of symptoms, we're seeing more data come out. You've got to get these into patients as soon as humanly possible, that these once again are saving lives and preserving hospital capacity because these patients don't progress to need hospitalization. I won't talk much about to the right. Once patients are hospitalized, just know as an intensive care doc, I'm incredibly proud of how this nation has decreased the mortality as time's gone on. A little bit about antibodies. These are monoclonal antibodies, so they're made from a mouse model. They bind to the virus, and just like the antibodies that our body produces, either block it from getting into the cell or present it to T cells for destruction. And once again, I know there's terrific ID and other physicians on that can talk more about that. This is the treatment eligibility. I won't read it to you. Obviously, these are EUA approved for a specific subset of patients. A patient has to be positive for COVID. It doesn't matter what kind of test was done. It has to be in the first 10 days of symptoms, so they have to have some sort of symptoms, and then you can read the eligibility criteria here. Once again, I think it's a little distressing that only about a quarter or a little bit less of patients who test positive and fall into one of these categories are getting these therapies. And we'll make these slides available if you have more questions. This is the EUA criteria for the 2 products. So the bottom line up front is these have been shown to decrease prevention. Once again, the earlier, the better. It's a single IV infusion. There are a lot of products in testing that don't require intravenous, but they're not at market or at the EUA stage yet. It's a single IV infusion. It's done typically in an outpatient. And once again, the data consistently is showing that it's a decrease of about 70% in the need for hospitalization. I don't say this to be coy, but this is not setting up an intensive care unit. This is an outpatient infusion with a single IV administration. The drug is over about 30 minutes and you have to monitor the patients for about an hour. So we've seen a number of fascinating and innovative models across the country, including what Dr. Fales has done using EMS providers to try and get together the team that can do this. I know that resources are constrained, and it's heartbreaking when we talk to hospitals and say, this would be great, but I don't have enough nurses to staff the ICU for night shift. How am I going to set this up? It's an interesting chicken and egg argument, because we know if we can get these therapies into enough patients, we'll decrease that deluge of patients that come to the ER and then, God forbid, need ICU care. So the bottom line up front is we've seen very interesting models of how to get these therapies into patients. I should also say 2 of my leadership colleagues from the federal COVID response are on the webinar today, Dr. Meredith Chuck and Colonel Deidre Tahan. So maybe during Q&A they can chime in as well. A couple of updates. There were initially 3 EUA approved products: BAM alone by Lilly, BAM Eddy by Lilly, and then the Regeneron cocktail. Because of really rigorous testing, both by the company and the FDA, it became obvious that BAM alone was not as effective against the variants. So the FDA, actually Lilly wrote to the FDA and said we should probably withdraw the EUA. Not to get too much into the trenches, but operationally, if an institution has BAM alone, the federal government through ABC can ship Eddy and thus make the cocktail. So once again, we've gone from 3 EUA approved products to 2, one by Lilly and one by Regeneron. This is probably one of the most important slides I'll show, and it's the fact the NIH guidelines have changed. Now that more data is coming in, now that this is taking on a real clinical route within the community, NIH has now changed the recommendation to strongly recommend. Because the data was early, NIH didn't have that recommendation at first. So as we talk to our medical colleagues across the country, and it's rare, but we still get a little bit of pushback, we can now say, based on the data, NIH is recommending these 2 monoclonals for the high-risk patients within the first 10 days. So this is the emerging data, and this is not a grand rounds presentation, and quite frankly, the data is still coming in. But if you look at the Lilly data, the Regeneron data in different trials, and I've highlighted sort of the high points. Once again, in trial after trial.
Anderson, I apologize for interrupting you. Could you put your slides in presentation mode? There's such great slides, and I want to make sure people see. I apologize.
Oh, technical malfunction. I'm so sorry. So. Sorry about that, Dr. J. I didn't know I wasn't doing that. Can you see the whole thing now?
We cannot, but it's okay. If you can continue on, we can just share the slides after the presentation.
Sorry. You think you've been doing this for 1.5 years and you know what you're doing. I'll try one more time and see if that does. Can you see that now?
No, if it's,
Is it still in just the preview mode?
and now I think we can see your desktop now as well.
Oh, that's great. Well, you can see what a busy day it is.
It actually got smaller.
Oh, thanks. So this will go down in the public speaking hall of shame.
If you
No,
click present online, it may work.
Present
It's at the top, third from the left. Present online, it might work.
Oh. On behalf of the government, that ain't gonna work. I am so sorry. I did this perfectly yesterday. New share. You don't want to see me. And then if I go to present, it's not present mode. Stop that. What do you see now? Oh, Dr. J, I'm so sorry.
I'm sorry, it's okay. Go ahead. Yep. If you can go back to, yeah, that's, I think, go ahead from there.
As big as possible. I'll move this over. Can you see anything now?
I think that is better. Go right ahead. Thank
I'm
you.
so sorry. So back to data. Can you see the data chart?
Yes.
Yes.
Thanks. So three EUA approved trials, and I'll just kind of get to the bottom line as I'm going to be a little over my time. Consistently 70% decrease in the need for hospitalization. Further trials, both from Lilly and Regeneron, larger numbers. And when we sit down and write the book about how we do this better next time, I think it's a fascinating notion of how do we take an EUA approved product and how do we get data back to clinicians in a more expeditious fashion? Because we've had a lot of docs across the country say, hey, this is really cool, but if we're enrolling more people in these EUAs, can we get more data on a quicker basis? And the other thing I will say is, and this is a really anemic slide, there's a lot of really cool papers coming in, including one that we wrote here at Health and Human Services. And whether it's UPMC, I know Dr. Fales has a manuscript in preparation, that magic number of 70% just keeps coming up, that if you get these patients early in their course, they're high risk, that 70% of these patients are going to avoid hospitalization. I'm going to preview a little bit about what my wonderful colleagues from Henry Ford are going to say. President Biden announced on March 17th of this year a $150 million investment purely in the therapeutic realm of the federal COVID response to get these therapies into the most vulnerable patients among us. And we've been very proud to kick this off in Michigan with Henry Ford. And once again, I know that my colleagues will be speaking more about it. We see this as a whole of community response. So even though this contract is through Henry Ford, like mechanisms of this terrific webinar, we want to make sure the entire community is engaged. How do FQHCs get patients to referral centers? How do docs learn more about this? How do we decrease any barriers, such as getting patients transported to these facilities? So once again, this is a whole of government response. How are we going to do that? Once again, this OTA mechanism, we can expand capacity at sites that are already ramping up. We can pop up tents We can do virtual support to help support the patient navigation. It typically comes down to staffing, and I think that will probably be during the Q&A, that we do have some staffing mechanisms. I wish I could wave some sort of federal magic wand and get more staff. That's obviously a laborious process because there's a finite number of nurses across the nation. And then finally, it takes terrific adventures like this. It takes hospitals and state health officials and the federal government all to do this together. And we've got to get word out. It's rare, but we still do have patients that don't trust in these therapies or don't trust in the process. And we've got to engage with community leaders. I deployed with our NDMS team down to El Centro, California to stand up one of these centers. And not until we had engaged with local faith leaders, the former mayor got treated, the former fire chief, once those folks were engaged, then word really spread to the community. So I'm anxious to figure out with Michigan how we can continue the terrific work you've done. So I'm sorry about my audiovisual errors. I will go back to square one on that. But once again, I am so proud to be working with the state of Michigan, and I look forward to Q&A.
Thank you. Thank you so much, Dr. Anderson. So next, we're going to hear a summary of our statewide experience by Dr. Bill Fales, who's our MDHHS State Medical Director in the Division of EMS and Trauma. Dr. Fales is a practicing ER doctor like myself and serves as a professor of emergency medicine at Western Michigan University School of Medicine. And I must say, I'm certainly grateful for Dr. Fales' leadership in this space over the past year. It is because of him we've been able to get so much out across the state. So Dr. Fales, please go ahead.
Good morning. Thank you, Dr. Khaldun. Just an audio check. I can be heard.
Yes.
Great. Well, thanks. It's my pleasure to be here this morning, and really just to echo Dr. Khaldun's comments. Thanks to everyone on this webinar for everything you've been doing for well over a year, and just a special appreciation also to our federal partners, Dr. Chuck, Colonel Tahan, Dr. Anderson, and the team at HHS has just been really great to work with. They send emails at the wee hours of the morning and are just super responsive to everything. So we really do appreciate that. Just for hopefully quick background, monoclonal antibody therapy in Michigan really kicked off in mid-November, shortly after the FDA issued their first of what was 3 and is now down to 2 emergency use authorizations for monoclonal antibody therapy. MDHHS was initially directed the shipments of antibodies. We made a policy decision kind of on the fly with only a couple of days notice that at that time, pretty much the entire state was being hit pretty hard with COVID. So we made a point of making sure every hospital had at least a small supply of monoclonal antibodies to start up with. And those hospitals that were being hit particularly bad received proportionally more. The intent was that the supply would serve as meet the needs of the hospital and the local healthcare system, but also would be more of as well a depot for the community, allowing for independent infusion centers and long-term care centers to have access to this medication. Over time, the supply became plentiful, we'll say, and the federal government made a policy decision to transition away from states making allocation decisions and allow hospitals to go directly to Amerisource, the supplier for the 2 currently authorized products. And so they order directly and it's shipped, and it's usually received within a couple of days. What we saw early on was not, I guess, real surprising, but variable adoption among our hospitals. We had some hospitals, and not just the large hospitals, but medium-sized and many smaller hospitals that felt that this was really an important tool in the toolbox to help mitigate admissions at a time when they were being hit quite bad with COVID. Other hospitals were a little more reticent and and were less willing to adopt this therapy for a variety of reasons. We found early on and over the past several months that not just hospitals could provide this therapy, but as mentioned, infusion clinics, long-term care, outpatient clinics, and home care. And Dr. Anderson was kind enough to mention our work with EMS in particular in providing monoclonal antibody therapy at home, as well as supporting long-term care facilities. From the state's perspective, our interest in this is really focusing on awareness, safety, efficacy, and assuring equitable access. And I think it's fair to say the state's philosophy is that the state of Michigan should not be dictating patient treatment to clinicians. That's the job of informed clinicians, but we're there to support and facilitate, but not to make those types of treatment decisions. In order to evaluate and monitor these 4 areas, we put in place, and we're really, I think, one of only a couple of states to do this, several different data systems, mainly, and what you'll see in the next few slides, will be data from our electronic patient profile, which is a relatively short survey that's filled out we ask to be filled out after every patient encounter, every infusion, and that feeds into a database. We also encourage hospitals, if they're made aware of a subsequent hospitalization or death, to complete a brief follow-up form on that patient. We also have done a small sample of probably less than 5% of the cases using medical students and pharmacy students to do phone interviews to see how patients have done. And finally, we receive data submitted weekly by hospitals and other infusers through EM Resource, as well as through HHS Protect, the federal government's portal. And then certainly last Wednesday, our governor and Dr. Khaldoun, during a press conference, spent a significant amount of time promoting monoclonal antibody therapy as a way to potentially reduce hospitalizations and deaths. This slide just shows kind of by week since the beginning of this program, the use of monoclonal antibodies in Michigan. We're now at over 8,200 reported uses, and we're pretty confident we have a number of others that have not reported. We understand that, but we do appreciate those reporting. But this is really, you can see how this is really ramped up. And this is the same time period with the case report. So you can see that big dip that was so wonderful to see in February. And unfortunately, we're now back on a mountain to the right that will hopefully end up being flat like a desert sometime soon. Just some very basic demographics, with one of the criteria being age greater than 65, one of the several high-risk criteria. Not real surprising that this age curve is skewed a little bit to the right, and we see a gender breakdown that seems to be appropriate. We also have treated 67 pediatric patients aged 12 to 17, and this is a group that we now have the ability to dive in and get a little bit more data on and see how they did. An important aspect of this intervention, along with other therapies that have been used and vaccinations and everything else throughout this pandemic, has been paying attention to racial disparity. And we're still below the 14% Black or African American state population. We're at 12%, kind of that gray slice of the pie. But that represents a 50% relative increase. We were initially down below 8%, so we are making progress there. Another area that we've collected some data on is just if any of the patients being infused, receiving this therapy, are healthcare workers. And we see 6% of our 8,000 plus patients falling into that category. But if you think about over half of the patients are over age 60, I suspect most of the healthcare workers are below age 60. I suspect that percentage is actually significantly higher. Among us, I would argue that that's probably okay with me. These are people that have, certainly been on the front lines of our healthcare system often. And if they become ill, I think we have a, responsibility to make every tool available to them to have a good outcome. This represents the breakdown of time from symptom onset to initiation of monoclonal antibody therapy. And it's, I think reasonably well distributed to cluster around day 5 and day 6. However, what we would love to be able to see is that shifted to the left, so that we'd like to try and decrease that time from symptom onset to receipt of infusion. The theory is the earlier one receives the therapy, the better the medication is at doing and neutralizing the virus. This looks at where the actual infusions have taken place, and this graph has been changing over the last several months. Over 50% of the infusions now take place in some type of a dedicated infusion area, and that could be a COVID-specific infusion area that was stood up for this particular process, or it could be some of the independent infusion centers. You certainly don't want to intermix COVID patients with immunocompromised infusion patients. So some places will do infusion center patients in the morning, the normal patients, and then they'll do the COVID patients in the afternoon. But that now accounts for the majority of locations. Emergency departments are just under a third of the patients, and that number has started out at over half, and it's just decreased, but still is a significant number. And then you see 3% at home, 3% in observation status, and a small number in long-term care. When we look at the therapies that have been used currently, and Dr. Anderson mentioned about the revocation of monotherapy with bamlanivimab. Certainly, we see bamlanivimab was a significant part of the pie. The combo of BAM and atezolizumab is about a third. And I think that really is striking, because that really has been out on the market for really just a number of, maybe just over a month or two. So that really shows a rapid response to those doing infusions to the new therapy when it came out. This looks at just some of the infusion-related symptoms that we see. One of the key things we want to look at is safety. Over 95% of these 8,000 patients report no infusion-related problems. Now, remember, these are all patients that have COVID, so and many of the infusion-related symptoms are also COVID symptoms. Importantly, no life-threatening allergic reactions identified, and we've had 11 patients that have had altered mental status, although it's not sure if this was from COVID or the therapy, perhaps the former. When we look at efficacy, we don't really have a control group in Michigan to compare, but when we look at some of those clinical trials Dr. Anderson described, we see in high-risk populations somewhere between a 9 to 15% hospitalization rate. So based on the hospital follow-up data, we're seeing about a 5.1% admission rate. Based on reports from hospitals that are doing a good job actively internally monitoring their admission rates. We see anywhere from 3.5% up to 8.3%. That 8.3%, I have to tell you, is in a community that is known for high vulnerable patients, very high risk patients. So I'd be curious to see what the rate would be without the therapy. And then based on the phone interviews, we're seeing a 4.6% admission rate. 2/3 of patients report feeling somewhat or significantly better after just 2 days, and 98% report feeling somewhat or significantly better at least 14 days when they received the call. So very quickly, just to profile the couple of things we're very happy with. The one is response to long-term care facilities that we consider kind of a mass casualty incident prevention when there's been outbreaks in these facilities. Cute name of Operation Holiday Delivery, responded to 7 large outbreaks in 7 different counties, 6 skilled nursing facilities, and 1 assisted living. And this was done with contracted state nurses as well as local paramedics. 120 patients treated, 3 admissions, and only 1 death in a super vulnerable population. And this just illustrates where EMS has been doing stuff with over 270 EMS delivered infusions in both the upper and lower peninsulas. And then just coming back to this slide that we had before, and trying to close out here by framing this in our new objective. So, these numbers look good in terms of the numbers look awful, sorry, but the number of infusions are certainly increasing. But to get to where we need to be, it's going to be variable based on what our activity is. If we see 1,000 cases a day, 7,000 cases a week, and to achieve this 50% of eligible patients, that's roughly 10% of the positives. That's where this is coming from. That requires us to do about 700 infusions a week in Michigan, and we're doing that now. So that we've got the ability to handle that. If we go to 2,000 cases a day, then we're talking 14,000 a week. That would be 1,400 weekly infusions. And then finally, if we go to 5,000, which is unfortunately where we've been recently, 5,000 a day, 35,000 a week, that requires 3,500 weekly infusions. And then finally, the return on investment or the potential return on investment. In an emergency management, we do planning assumptions. So based on one clinical trial, looking at a number needed to treat to prevent one hospitalization of 20 and one death of 50, based on that premise, if we look at what we've done already with, say, 9,000 infusions, realizing that they all haven't been reported, that would translate to 450 fewer admissions and 180 fewer deaths. I think that's pretty significant. But if we were to have applied this standard of, or this objective of 50% to the eligible patients over the last month, what that potentially could have translated to is 150,000 to 5,000, I'm sorry, 7,500 fewer admissions and 3,000 fewer deaths. And if the numbers are off, if it's 100 number needed to treat to prevent one death, that's 1,500 fewer deaths. I think we have to agree that that is a significant return on investment. It's theoretical, but I think it's worth pursuing. So Dr. J, sorry to go over, but thanks for the time, and back to you, ma'am.
Thank you, Dr. Fales. Again, really, really important work. So our next speaker is Dr. Lindsay Petty. Dr. Petty is a clinical assistant professor of medicine at the University of Michigan and a practicing infectious disease physician at Michigan Medicine. She's also the medical director of their monoclonal antibody program. So go ahead, Dr. Petty.
Thank you, Dr. Khaldun and Dr. Fales, for inviting me to talk about our experience for just a couple of minutes at the University of Michigan. So back in November, when the first EUA was launched, our first problem we wanted to solve for was how to get patients the infusion as quickly as possible, as has been highlighted by Dr. Fales and Dr. Anderson, really wanting to make sure that we could get these treatments in as quickly as possible. And we knew that we couldn't control for the time from patient symptom to test, but that we could try to control that time from test result to infusion. And so we felt that the best way to approach this would be to really cut out the middleman and take out the referral process for the majority of patients, and instead create a centralized screening process where we could actively screen COVID positive patients with eligible comorbidities. And so that's what we did, is we created basically harnessing our electronic medical record to be able to identify patients with a COVID positive test and potential eligible comorbidities. And they are sent basically to an in-basket that gets reviewed every day by a team of trained pharmacists who then call patients directly, discuss the therapy, and do the consent process over the phone, and then get scheduled. So a huge way that actually the electronic medical record has been really helpful for us. And we felt that this was more efficient, but also had the possibility of being more equitable, because we weren't then relying on different providers to be as up to date on these new therapies. We utilized private rooms in our infusion centers, given that both back in November and now our emergency department really is overwhelmed, and there just is not the space to be doing these infusions there. And so we worked with infection prevention to identify the best location to be doing these infusions, which did require moving some scheduled infusion patients for non-COVID reasons to other spaces, but luckily we were able to accommodate that. And we originally focused on really Michigan Medicine patients and Washtenaw County patients, but have been able to expand outside since then. And as of Wednesday, we'd completed 898 infusions, of which 830 were outpatient. So some, being for COVID patients who are admitted for other reasons. And of those over 800 patients, we're seeing, just as Dr. Fales is discussing, 3.1% hospitalizations and no deaths in patients who are infused in the outpatient setting. So really impactful and consistent data. But of course, with this more recent surge, even the system that we had built back in November and expanded upon was really stressed. And so we've tried to do different things to still be able to handle the capacity that we need. So really, with our process, we then had two major bottlenecks. The first was the screening and consenting process, as the number of positive results that we had to screen tripled, or more than that even. and then the infusion chair capacity. So we trained additional pharmacists to be able to do this work, but also utilize other kind of creative staffing models where a pharmacist wasn't necessarily assigned to be doing the work, but because we had enough people trained, they could jump into the in-basket if they had an extra 15 minutes during the day and really help with the load. So that's been incredibly useful. And our pharmacist team has just been amazing. And then the other bottleneck was the infusion chair capacity. So we utilized additional private rooms, but that became a limitation. And so then we have worked to extend our hours, and our nursing staff has just stepped up amazingly to take this work on. And so both extended hours Monday through Friday, and then opening up over the last couple of weeks our Saturday clinic as well, and expanding upon that. In addition, we've expanded outside of our walls, and we've partnered with local EMS, as Dr. Fales has described too, and have partnered with Huron Valley Ambulance and Livingston County EMS to be able to do infusions in the home for some of our patients, and also for home med. And that's been really helpful in us being able to work through this surge. So I think some key takeaways from our experience are that one, really focusing on utilizing different staff in different ways. And I know other programs are using nurses or APPs, and I think you'll hear more about that. But really, we felt like the centralized screening process has been able to help us be really proactive and identify as many patients as possible and get to them as quickly as possible. And also just reaching out to your local EMS to see if there's ways that you can partner to help expand further from there.
All right, thank you. Thank you, Dr. Petty. Certainly appreciate your efforts and that centralized approach and using different staffing models and the partnerships. So now to provide a description of another successful therapy project is Dr. Banesh Patel, who is the Chief Medical Officer for McLaren Hospital in Flint, also an emergency medicine physician, and previously was the Regional Medical Director for the Region 2 North Healthcare Coalition. Go ahead, Dr. Patel.
Thank you, Dr. Caldoun, Dr. Fales, for inviting me to present what we've done here at McLaren Flint. So chronologically, if I go back to early November, my director of pharmacy here at the hospital, Susie Wilson, approached me with this treatment that was showing promising results, as Dr. Anderson pointed out, 70% reduction in admissions. And as we were seeing the uptick in cases in November, we thought, okay, why not? Let's give it a shot. We were trying to find a good place to try to do this, and our infusion center, unfortunately, was just too small to do this, and the logistics of trying to organize. Unfortunately, we weren't able to replicate what Dr. Petty described at Michigan Med. So I am an ER physician, and I thought, what about trying to do this straight out of our emergency department? And so when we received the drug, I believe it was on a Tuesday, we took the next 48 hours to try to figure out how to do this. And I have to be honest, I never thought that we would hit the numbers that we've been doing since November. I thought, we might get lucky and do a couple of treatments a week. So that Friday, I went down to the ER to educate my colleagues and the staff, and just got lucky that there were two physicians that, two patients that came in right at that moment with positive test results and met the criteria. And I said, okay, let's give it a shot. Now, sometimes we get lucky. One of those patients, it was a husband-wife, but the husband happened to be part of our medical staff, and essentially became the face and champion of the program here. And I can tell you that 14, 15 days later, he was actually back to work. And so that success story was very, very helpful in trying to communicate how this drug could be useful in trying to reduce admissions and improve the care and treatment protocols that we have for COVID. So that first week, we started to ramp up. Our two pulmonary groups here in town were 100% on board, and our two ID docs, and we're very, very supportive. We started off with this soft launch where we didn't really advertise it, but they encouraged me to advertise it. And so in late December, we finally put out a communication to the entire medical staff in the county about this, and provided all of the criteria and how they could send patients directly to the emergency department to get the treatment. We are fortunate to have a standalone emergency department in Fenton as well. And shortly after that, we started to introduce this at Fenton so we could offer a second site. So these are the ways that we've been successful to date. I believe that we've treated about 400 patients. We've seen maybe about a 5-6%, maybe just a little higher admission rate. And so it's been very, very successful in my opinion. And we've seen a tremendous buy-in from the community and locally here within the hospital with our emergency department, our pulmonologists, and our ID physicians. Thank you.
Thank you. Thank you very much for sharing that kind of real world experience. So our final presentation this morning is on Operation Crush COVID, which is the White House initiative that Dr. Anderson alluded to expand monoclonal antibody access in the metropolitan Detroit area. Presenting from Henry Ford Health System will be Jane Thornhill, who is the Vice President with the Henry Ford Physician Network and ACO. And we also have Dr. Bruce Muma, President and CEO of the Henry Ford Physician Network.
Good morning. It's a pleasure to be with you. As Dr. Anderson stated earlier in this presentation, Dr. Muma and I are here to share with you what represents a community health initiative with Henry Ford Health System serving as the anchor health organization to convene the Southeastern Michigan community to increase Mab infusions treatment to qualifying patients. And with that, I'm going to start some slides because I know we're short on time and hand it over to Dr. Muma. So Bruce, it is yours. Let me do that share. There we go. Okay. And tell me if you can see, no, you want to see my screen, don't you? There we go. And it's being cranky for me too.
We are seeing your calendar. There you go.
There you go.
Right. No, it switched back to your calendar.
Oh boy, oh boy, oh boy. Let me try to do this. Let me do this. I'm sorry. It is really being cranky. Okay. I'm going to get up to the top slide here and try it one more time. There, Bruce, go ahead and take it.
Yes. Well, thank you, Jane, and good morning, everyone. We appreciate the opportunity to share our experience with you, and we'd be delighted to collaborate or partner with others on the call to expand Mab treatment in our communities. We have just 3 slides, and you can go to the first slide there, Jane, which will provide an executive summary. We're going to start here with a snapshot of our volume trends and our demographics. The top graph shows our volume trends starting in November when we launched our first acute respiratory clinics. These ARC clinics were ambulatory centers designed to treat COVID positive patients, including providing Mab infusions. As the third surge began, we decided to close those ARC clinics and focus primarily on expanding capacity for Mab infusion as quickly as possible. And you can see as the third surge started, we were able to quickly increase our volumes. Over the past 2 weeks, you can see a further increase in volume as we began to collaborate with HHS. And in those 2 weeks, we intensified our focus on outreach capabilities, as well as increasing the total capacity for infusions by adding chairs in more locations. This week, we're on target to exceed 250 infusions. And based upon how the surge goes, we have plans to expand the capacity further up to as many as 700 infusions a week. I think somebody in the chat room asked about what our plans are with respect to being on the downslope of the surge. And we're really just going to have to play it by ear, one day at a time and decide about expansion. Our total number of infusions from the very beginning is now up over 1,140 infusions. On the bottom of the graph, you can see our demographic characteristics of the patients that we've infused. We know that it's really important to monitor the success across all of our populations in the community, and we hope to have some time as the surge dies down to compare infusion rates and COVID positivity in these various populations. These slides will be available so that you can dig into the details later. The next slide is really intended to sort of show the Mab infusion workflow, starting with the sources of patient referrals and then ending with the infusion centers. This model reflects several cycles of improvement as well as input from the other HHS collaborators around the country. Now, starting at the top, you can see we have 4 portals now, 4 patient portals. On the left in blue, you can see the original portals which have existed from the very beginning. These portals are dependent on physician referrals to capture patients. And in particular, patients that have a PCP or PCP and having PCPs who are particularly good at monitoring their panels for COVID disease. Now, on the right, we have added 2 new portals in the last 2 weeks, and they're in orange. And these are patient-focused portals that offer infusions to candidates who may not have a physician or whose physician has yet to refer them. And I think this highlights what Lindsay Petty was talking about earlier, which is creating that or taking out the middleman, if you will, and actually going right to the patients and trying to get those patients in as quickly as possible. At the center of the workflow is what we're calling the Mab Infusion Hub. The hub manages an ongoing master list of candidates, which is populated by each of the 4 portals. The Mab Infusion Hub is Our Mab Infusion Hub is staffed by APPs and RNs who have delegated authority to assess, educate, consent, arrange for transportation, order, and then schedule the Mab infusion at a convenient location or in the home. The hub staff also provide clinical coverage for the infusion centers to manage such issues as infusion reactions or patient decline. The hub is really the brains of the care system, which is attempting to see and touch all of the COVID patients that are candidates in the community. Now, I think one of the things we've learned is that in order to really see and touch all of the patients that are in need, we need a much larger commitment to data integration and collaboration amongst the various healthcare institutions across the state. And I think that's actually the purpose of this meeting. The bottom of the workflow shows our current infusion sites, which are geographically distributed to serve the population. On the left, you see one in orange, and that's actually not a Henry Ford site. That's a federally qualified health clinic, and we have set up an infusion center in that clinic. And then on the right, you can see in gray where we hope to go in the future in our quest to expand access to underserved populations in Southeast Michigan. We hope to tap into contact tracing to start that conversation with COVID patients, as well as to work more directly with other community healthcare organizations who are managing COVID patients. We believe that the Infusion Hub can really serve as an air traffic control center for a large portion of the community, and we would love to share that resource with others in the community. We're also looking at sponsoring additional infusion centers at other sites within the community, again, based on what happens with the surge. And the last slide is really just our attempt to capture lessons learned at this point in time. We are going to learn many more lessons, but these are the ones that bubble to the top. And the first one, and maybe the most important one, is that this Mab Infusion Hub is a great concept, and we think all roads should lead to that Mab Infusion Hub. And I think Lindsay Petty also pointed out that learning at University of Michigan. Secondly, leveraging the EMR to identify Mab infusion candidates is critical. We're using Slicer Dicer in Epic to identify those candidates using the clinical criteria and COVID positivity. Reaching out into the community, I think, is another key thing. We need to communicate, collaborate, and coordinate with those in our community. And we've done a lot of work so far with our federally qualified health clinics and our health departments. Communication and marketing has been challenging, physician bandwidth, and then just the ongoing evolution of COVID with changes in treatment, changes in surge, changes in CDC policies, and so forth. Another key lesson for us was nursing competency. In the last 2 weeks, we've added a lot of nursing staff to expand our infusion capacity, and we've used contingent nurses, we've used agency nurses, and if the nurse has experience in infusion centers or in the emergency room, you can certainly achieve a 3 to 4 to 1 ratio for patient to chair, or patient to nurse. But if the nurse does not have any competency, it's really hard to get much above a ratio of 2 to 1. Lastly, or almost lastly, access to data at the community level is critical. We haven't had enough of that. We really need to understand what this supply and demand is within each community to better attack this problem. Good. We know that time is of the essence right now, and so getting as many people into infusion chairs is key, and not waiting for perfect is a key lesson for us. So I'll stop there. Jane, did you have anything to add?
No, thank you, Bruce.
Thank you. Thanks, everybody.
So thank you very much to all of our presenters. We only have a few minutes left, and I think we'd like to try and address some of your questions. So if you could, please use the raise your hand feature, and we will see if Sean can call on you. We likely will not get to all of the questions. If you want to put your email address in the chat function, we will certainly follow up with you. So Sean, do we have anyone who would like to ask a question?
I'll start with the ones I see in the chat, but are there any statistics from anyone on the number of treatments for pregnant women?
I can say at Henry Ford, we haven't looked at that, but we could. That's a great question.
To mirror that, yeah, we haven't looked at that, but I would say we've treated probably more than 25. And honestly, it's been more recently in the last couple of weeks that I think with younger populations and also maybe pregnancy being a reason that some patients have not gotten vaccinated, that we've definitely seen a pickup in pregnant women that we've been treating.
Another question from Don. Is anyone doing treatment by walk-in after a phone or web-based screening in coordination with a testing site, or just by appointment?
I think at Henry Ford, we've created a pathway where a patient who is in the emergency room or in an urgent care setting could potentially walk in. It's not an easy process, but we have created that pathway.
I can tell you at McLaren Flint, we take walk-ins 24/7 in our emergency department.
And then is the same monitoring done for the in-home infusions?
Yes, it's basically the same as in a hospital or an infusion clinic. What we recommend is vital signs every 30 minutes for patients that have stable vital signs. If they have abnormal vital signs at the beginning or at any point, then we increase that to every 15 minutes or as needed.
And then where do you store the medicine and who compounds it?
The medication needs to be stored in a medication refrigerator, and the compounding, it's important to understand the compounding is not complicated, and we have paramedics and nurses doing it in nursing homes and in homes. So when it's out of the hospital, there's some advantage of mixing in the medication at the site, so you don't waste it if the patient's condition changes or they change their mind. So it's very easy to mix up. It doesn't require pharmacy in infusion rooms or whatever to prepare. You can certainly do that, but that's not a requirement.
Okay, thank you everyone. We are out of time, but this has really been a great webinar. Thank you to all of our presenters. We do have a website on monoclonal antibody therapies, michigan.gov/COVID therapy. This webinar will also be recorded and placed on the MHA website. So thank you everyone for your time today, and of course your partnership as we fight COVID-19 in the state. Thank you and have a great day.